All right. Hello, welcome everyone to the second session of the APDA Northwest Beyond Medication series. This one is called Understanding Balance and Falls and Parkinson Disease. Last week, we were joined by Dr. Nate Coomer from the Parkinson Fitness Project, talking about why falls happen and what is the science behind it and what are the increased fall risks and that kind of thing. There is a recording on YouTube if you haven't watched it. Then go back and watch that on the YouTube channel. Today, we are joined with Dr. Jenny Alex, who is here next to me. And she is also a doctor of physical therapy who at the Parkinson Fitness Project. And she is going to talk about training the balance system, practice and practical things, and why you actually train the balance system. So we are going to talk about that today. So Jenny, thank you very much for being here. Thank you for being a part of this program. And I'm going to disappear and let you take it away. One thing, if you do have questions, you can put them in the chat and we will do an open Q&A at the end or during the program, whichever Jenny would like.
Hi, everybody. I am going to go ahead and share my screen here. And then, Jen, you disappeared, but let me know, can you confirm if you can see the share?
Yes, I can.
Okay. So, like Jen said, I am also a physical therapist at the Parkinson's Fitness Project. I'm going to be giving a talk today about training different systems we use to balance, and try to go into a little bit about what to practice and why. So, I'm really passionate about helping people understand the why behind exercise. I think it's good if you're somebody that works with a physical therapist to understand their rationale a bit more about the interventions they choose, and then to understand the why of some of the exercises we might recommend for you at home. So we have a few goals for today. So what we're going to spend time talking about first is we're going to highlight the different sensory systems that our brain uses to balance. We're also going to talk about how Parkinson's disease affects these different sensory systems. And then we're going to spend time at the end talking about things that you can do to more effectively train your balance. So, sitting here right now, your brain has a sense of where you are in space. So, am I stable? Am I off balance? This is something that we take for granted until something has gone awry with this system. So, much like the sense of smell or sense of taste, we have this sense in our brain of where we are in space. And so there are three main components to this system. So to stay upright, our brain, think of it as this internal GPS, and it's getting input from three main sensory systems. So you can see in this diagram, there's input into the brain from our eyes, from our body, and from our inner ear. And our brain is constantly processing these different senses. And so the first of these senses is vision. So you can see in the room right now, if you're upright, you can see how you're aligned to different objects in the room. You're using vision to determine where you are in space. We're also using a sense in our body called somatosensory. So this is kind of made of two main components. So I can feel the ground under my feet and under my hips. I just sort of have a sense I have a sense of the ground on my feet. But I also have a sense of where my joints are in space. So I can feel that sway through my ankles. We call that proprioception. The third sense that we use is the vestibular system. So this is our inner ear. Our inner ear tells us where our head is in space. It also has a role in eye-head coordination. So I explain this to my patients. So we're using eyes, feet, head, and our brain is constantly comparing those three inputs. So if my head falls to the side, to my inner ear, that's a fall. My head is tilting in space, but my brain can quickly compare to my feet and say, okay, we're not falling. Your feet are still solid. If my head falls to the side and my weight shifts, tips on my feet, my brain is able to register, okay, that's a fall. And now let's put out your arms so that you catch yourself. So again, this constant comparison. What do I see with my eyes? What am I feeling with my feet? And what is my inner ear sensing in terms of where my head is in space? So let's take a pause for a minute and talk a little bit more about that head sense of balance. So our inner ear, if you look at this diagram, we have the outer ear, the ear canal, there's the eardrum, and then sitting back behind the eardrum is our inner ear. It's made of two main components. So in blue on this image is something called your semicircular canals. And these are literally canals filled with fluid, and they sense head rotation. So if your head rotates side to side or up and down, the fluid in those canals move, and you can sense that motion. The other component of our inner ear is the otolith, and that's in this image in orange. Think of the otoliths as jello with rocks sitting in the jello. So you can think about if you were to accelerate in a car, those rocks would shift on that jello. If you were to go up or down in an escalator, those otoliths are sensing that linear movement. So our inner ear is sensing rotation and then linear movement. Okay, so we have eyes, feet, head. All of that information comes into our brain, and our brain has to process it. And like we talk about, it then has to send signals to our muscles to anticipate and react to balance challenges. The problem is if those systems aren't communicating well, and if there's a mismatch in those systems, it can result in dizziness and imbalance. So I often explain the sensory mismatch a few different ways. So something that you may, a sensory mismatch that you may have experienced is if you're in a car and you're driving on a curvy road and you're trying to read a book. The book and the words on the page are stationary, but you're feeling all of the movement in your inner ear, and your brain can't make sense of that movement versus the stationary page, and you start to feel motion sick. Interestingly, you can take Dramamine for motion sickness. And what Dramamine is actually a vestibular suppressant. So there's this mismatch happening. I'm trying to read the book. I'm feeling this motion. What Dramamine does is it blocks that GPS input from our inner ear, and it reduces that mismatch and then hopefully alleviates that motion sensitivity. You can think about that when you're driving, often the driver doesn't feel motion sick. And that's because they're not having as much of a mismatch. So if I'm driving on that curvy road, I'm looking out the window, I'm seeing the curve. My brain is more prepared for what it's about to feel. And so you're not getting that as much of that motion sensitivity. Another example of sensory mismatch that you may have experienced is if you've ever been in a car that pulls up next to a bus and the bus starts to go, and for a moment you feel like you're rolling backwards and you slam on your brakes. Again, there was a mismatch. The car wasn't moving, but because your brain got confused for a second, it was over relying on that visual, seeing the bus roll. You felt physical movement and slammed on your brakes. So you can see sort of how powerful that sensory mismatch can be and why it could potentially result in imbalance. So if we have this GPS system, when I have someone come to the clinic and they tell me that they're off balance or they're falling, the first thing that I want to do with them is just see how accurate is the information that they're getting from their eyes, their feet, and their inner ear. So I often think of this as a software problem. So if my computer isn't working, first step, I just want to make sure it's plugged in. I want to make sure the screen isn't cracked. I want to make sure the cord hasn't been cut. We just want to first look from a hardware perspective at what is the status of those three main sensory systems. So let's start with vision. Vision is really important for balance. So I want to optimize how my patients are seeing. So, at a simple level, I just want to make sure that someone has an up to date prescription for their contacts or their glasses. Again, if someone comes in and tells me they're experiencing a lot of their falls in the middle of the night, and Amy will talk more about this next week, but we might just have to optimize vision a little bit. So something like night lights, they need more input, visual input to be safer. Another thing that I talk with some of my patients about, again, we take for granted how much information our brain has to process. And sometimes I really try to simplify someone's glasses. So if you look at the bottom, that is showing what it looks like to have progressive and bifocal lenses. And sometimes what happens with my patients is because Parkinson's affects how we're processing all of this sensory information, it's tricky for them to use progressive lenses. I know they're more convenient, but just yesterday I talked with a patient about when he's hiking, he's experiencing imbalance when he's hiking, that we're going to get him a pair of just single lens distance frames to help him when he's out on the trail. Another thing to think about with vision, and I don't see this as much anymore, but sometimes when someone has a cataract repair, they would offer something called monovision. And what that means is when they repair the cataract, one eye is for reading and one eye is for distance. That can be really tricky for anyone, but especially someone with Parkinson's, because again, it's just making vision too complicated. How Parkinson's affects the visual system is some of my patients have double vision, and double vision is a result of poor coordination of the eye muscles. So if my patient is having double vision and that's we think contributing to their falls, oftentimes, I will send them to a neuro-ophthalmologist. That's an eye doctor who has specialized training in helping people with neurologic conditions. And they can get the patient prism lenses, which is essentially if there's a skew in their eyes, the prism lenses can pull the eyes back in focus so they're seeing a single image. Okay, so next we have to optimize the somatosensory. Again, how well is my patient feeling the ground under my feet? How well are they feeling sway in their ankles? A really common comorbidity is my patients with Parkinson's also have something called peripheral neuropathy. And what that is just a numbness in their feet. So they're not, it affects the nerves in their feet. They might experience numbness or tingling, but it can result in difficulty feeling the ground and feeling movement in their ankles. So, unfortunately, at this point, I can't repair that nerve damage, but I can optimize the contact of their foot with the ground. So, I really want my patients in stable footwear. I have pictured here a lot of us here at the clinic really love Brooks shoes. But any sneaker that's a stability shoe tends to give my patients more support. Something like a Hoka shoes are designed, they can be really good if someone's having foot pain, but Hoka shoes are very padded. So you can imagine if you have some numbness in your feet and you're having trouble feeling the ground, and then you wear a really padded shoe, that's not often the best fit for someone with neuropathy. If someone's neuropathy is really severe, um, they really can't feel their feet much at all, we might have to pull in an assistive device. So trekking poles or canes can be really helpful because they give the patient a sense of the ground. It just helps you feel the ground through the pole if you can't feel it through your feet. How Parkinson's affects the somatosensory is Parkinson's disease can cause the ankles to be rigid. So if I have more stiffness in my ankles, that can affect my proprioceptive feedback. So you can see in this corner picture, working on ankle strength and flexibility is really important, and we'll talk more about that later in the talk. Okay, the vestibular system. So when someone has a condition that affects the function of their inner ear, oftentimes they will experience vertigo. And what vertigo is a spinning sense of dizziness. My patients experience dizziness a lot of different ways. But if their dizziness, oftentimes they'll do this with their arm. They feel like they're spinning or the room is spinning. There's a potential that they have something affecting the function of their inner ear. There is a division of physical therapy called vestibular PT, and essentially a vestibular PT is trained in helping patients with inner ear conditions. Here at the clinic, myself and another one of our therapists do have vestibular training. But if you're experiencing a lot of vertigo, you might want to be seen by a PT with vestibular experience. We're not going to spend too much time, but just know a few of the main inner ear disorders that we see. One is called BPPV. We're going to talk about that in the next slide. That's if you've heard someone talk about something wrong with the crystals in their inner ear. Another condition is vestibular neuritis. So this is almost a vestibular attack. Um, if you've ever heard of Bell's palsy, it's this viral attack on the facial nerve, and essentially someone develops drooping on one side of the face. Vestibular neuritis is a similar viral attack on the nerve that affects the inner ear. So often people experience like a sudden onset of nausea and vertigo. And then finally, vestibular migraine. And so think of everything you know about migraine, except instead of a headache, people have these episodic bouts of vertigo. So I want to spend 1 minute diving a little bit more into BPPV. I So benign, it doesn't feel benign, but it's this episodic vertigo that is not as dangerous as it feels. It's paroxysmal. It comes and goes. It's positional. It's triggered by certain positions, vertigo. So patients will often describe I roll over in bed or I tip my head back to put in eye drops and I get this 30 seconds of spinning. So, what this BPPV is, if you remember, I was talking about the otolith and how there's jello and there's rocks sitting on the jello. So what happens is if one of those rocks gets dislodged, these are calcium carbonate crystals. If they get dislodged and they're floating in the semicircular canals, what happens is when you roll over in bed or you tilt your head back, you get movement of that crystal and you experience this vertigo. This can happen spontaneously, but it can happen spontaneously and contribute to falls. But it's also important to discuss it in a balance and falls talk because sometimes when people fall and hit their head, they can dislodge one of these crystals. So if I have a patient who's fallen and they start experiencing this episodic vertigo, it's really important to get screened for BPPV because it's actually very easy to treat. And so what you do is you essentially take the patient through a repositioning maneuver. They lie back and roll over and sit up, and literally we get that crystal to leave the central or the semicircular canal and dump back down into the otolith. So, how does Parkinson's disease affect the inner ear? With aging, there's a loss of function in the vestibular system. So, the example I always give is that when I go to the park, I have young children. My children can go on the merry-go-round and spin and have the time of their life. And for me lately, even going on the swing makes me feel a little motion sick. So, I know that I've lost some function in my inner ear. If it was something that was really meaningful to me, I could regain my ability to swing. I choose just to not partake anymore. But you can improve the function of your inner ear. In Parkinson's disease, there's sort of this added damage outside of what occurs with aging. And if you've heard people talk about Parkinson's disease being caused by clumps and misfolds of alpha-synuclein protein, this protein can deposit on the vestibular nerve. And there can be weaker signals from that otolith. So again, we just looked eyes, feet, inner ear. Are those systems even working? What kind of input is our brain getting from those sensory systems? Next, what we want to look at is the main way that Parkinson's disease affects these sensory systems is actually, I think of it as a software problem. So all of that information from our eyes, feet, and inner ear comes into our brain, and our brain has to process and make sense of it. And so Parkinson's disease results in slowed central processing. So it takes longer to process visual, vestibular, and somatosensory input. And so there's this little glitch or a lag, but that can have a big impact on balance. So a lot of what Nate talked to you about last week can be explained by some of this sensory processing dysfunction. So if I'm having trouble coordinating visual, proprioceptive, vestibular information, I'm having a little bit more trouble feeling where I am in space. So you might have had, a significant other or a caregiver notice that you aren't swinging one arm as much as the other. You can't necessarily feel that you aren't swinging your arm, but other people notice it. So you're having trouble feeling your body in space. Again, if there's a little glitch, so if I'm a little bit slower in anticipating and reacting to a stumble is more likely to turn into a loss of balance for somebody with Parkinson's. And again, if I'm having trouble processing these inputs, often someone with Parkinson's can be a little bit more unstable on uneven surfaces. So we're going to take the example of this hiker. And so you have to think about like he's walking on this trail and he's having to process all of this information. He's having to feel the incline through his ankles. He's having to feel the uneven pavement or rocks under his feet. He's having to visually determine, is he lined up on the trail? And then his inner ear is as he turns and looks at different things along the trail, he's getting this vestibular input as well. And so here, here's a scenario that could happen to someone with Parkinson's. So he's coming up to a rock and he has to step his foot over his rock or step his foot over the rock. And unfortunately, because he can't feel that he's shuffling his foot a little bit, his toe catches on the rock. So his toe catches on the rock and then he starts to stumble. Well, this catching of his toe is then compounded by it takes his brain, a millisecond longer to feel that he's falling and he isn't able to catch himself. And so again, instead of a trip, it turns into a fall. So we're gonna dive a little bit deeper into this difficulty with sensory processing and how it plays out for individuals with Parkinson's disease. So one consequence, if my brain is having a little bit of a harder time making sense of all of these sensory inputs, one thing that happens in my patients with Parkinson's disease is they can become very visually dependent for balance. So again, if my inner ear is a little bit weaker, if I have a little bit of numbness in my feet, I'm going to really use vision more for stability. And that's common in older adults, and it's even more common in individuals with Parkinson's disease. So you can think about if you have to walk to the bathroom at night or close your eyes to rinse out your hair in the shower. When we take vision away, it can result in a lot of instability. This also comes into play walking in really busy environments. So this picture in this Costco or Home Depot, I'm not quite sure what we're looking at, but with this busy store, when I walk into this store, if I'm trying to use vision for stability and everything's moving and the shelves are really busy and the space is cluttered, I'm going to feel it's almost I'm going to feel very uncomfortable in this environment because my whole visual world is moving. Thinking back to this hiker, visual dependency can also have this overlay with posture. And so I'm going to go back to my soapbox of bifocals. So if you think about it, if I'm an individual with Parkinson's and I'm visually dependent for balance, if I'm on that hiking trail and I'm trying to step over a rock, and the thing is, I really have to see what's happening because I can't quite feel if my foot is clearing the rock, and I'm really using vision to help me feel balanced. What happens is if you look straight down through your glasses and you're looking through the reading portion of your bifocals, if I look straight down, I can't see that rock. So sometimes what happens is people end up really having to tip their head forward so that they can use that upper part, that distance portion of their glasses to clear obstacles. So that's one reason posture is impaired with Parkinson's disease. The other thing is we're going back to that sense of where I am in space. So feeling through my feet and my inner ear and vision, I have a sense sitting here right now of what is vertical. And one thing that happens in Parkinson's disease is individuals very commonly have an impaired sense of vertical, and they can't necessarily feel that that's happening. So I had a patient yesterday who said that he's surprised when he sees himself in the mirror and that he's bent forward. This impaired sense of vertical often affects people's posture in two different ways. So one is people can be a little bit more bent forward. And one is people can be tipped to the side a little bit more. And we use terms that bending forward is called camptocormia. So what is that crazy word? What camptocormia means is your posture is bent forward when you're upright against gravity. But oftentimes, so I can have a patient come in and they're really stooped forward, but when I lay them flat, they can get totally flat, no pillows. So again, it isn't a spine problem. It's that when they come upright, they don't know where vertical is and they're tipped forward. This is different than someone with arthritis. If at a spine level, someone's spine is bent forward, it doesn't change necessarily when they're upright or lying down. So when someone has pretty severe arthritis and I try to lie them flat, oftentimes they need like 3 to 4 pillows. They can't get themselves all the way flat. And then same thing with this Pisa syndrome. It's this tendency to have this shift in the frontal plane. So the reason that this impacts balance is it shifts how my weight is distributed. So if you can imagine if I'm tipped to the side, if you think about the foundation under my feet, I'm in a precarious position. My center of mass is way outside my base of support. And so sometimes, something like festination, which is sort of this falling forward with a lot of little steps, it's almost because it's often caused by posture. It's if I'm out in front of my feet, I start to fall forward. So it's important, pretty much all of my patients, but especially my patients with these different posture syndromes, to reset their posture every day. Um, I want my patients to have some sort of because what we want is we don't want their spine to get stuck in that forward or side bend position. And so one of the best ways to do this is to lie flat on the floor. Again, we're taking out that sense of vertical. We're just lying flat on the floor and trying to make sure that everything stays nice and stretched out. So Nate talked about how freezing of gait can contribute to falls and imbalance. And again, we can describe freezing of gait with this concept of a sensory mismatch. So I think of freezing of gait as a traffic jam. It's this traffic jam of sensory information. And in the face of overload, what our brain does is just hits the brakes and our feet get stuck. So you think about if you were having to cross this crosswalk, there's so much happening. I'm having to step off the curb and watch for traffic and look at the traffic light. In these situations where there's all of these different sensory inputs, that can sometimes trigger a freeze. So doorways, getting onto an elevator. The brain is having trouble processing visual information in that crowded space, and somebody gets stuck. Turning is another common freezing trigger. So you think about that's like a lot of vestibular information. I'm having to process my head moving in space. And then with this traffic jam analogy, you're processing vision, somatosensory, inner ear inputs, and then let's say you're trying to read a text message on your phone on top of it. So multitasking can sometimes be the trigger of a freezing episode. So so how do we help somebody with freezing? One way to clear that traffic jam is to give somebody a very clear sensory cue. So think about like staring at the horizon. It's giving you a clear sensory cue to pay attention to. So sometimes if you're frozen and you have lines to step over, that visual cue can help break the freeze. Counting, so an auditory cue. So you will have people count 10 big steps to get through a doorway. That's sort of their sensory anchor. There's a lot of research right now on the use of vibration. So they're researching vibrating shoes and vibrating socks. And so the idea is if you're somebody that freezes crossing the street, if you could have this something about that sensory input from that vibration has been shown to reduce freezing episodes. Okay, so we've talked about what is the accuracy of the different sensory systems and what is happening when these systems try to communicate in the brain. And there's this, like we talked about, the glitch or the lag. So, with all of this in mind, how do I start to work on this with one of my patients? So, one thing we really want to do is improve someone's body awareness. So, I want to make you better able to feel where you are in space. And I really want to address that posture and that sense of vertical. So, thinking about again that you're maybe not swinging your arm, but you can't necessarily feel that. You're maybe stooped forward, but you can't perceive that. We really want to train big. So we do large amplitude movement training. If you've heard of LSVT or power, and we're going to do a little bit at the end, but it's the idea of I want you to stand up tall. I'm going to over exaggerate. I'm going to do this really big movement and overcorrect because this has become the middle for you. So I want to recalibrate. I always tell my patients, think of this as your recalibration so that you can feel where you are in space a little bit more. I also want to give you more sensory feedback. So if you've heard about boxing for Parkinson's disease, boxing is really good. There's a lot of hitting that heavy bag really helps. That's a lot of proprioceptive feedback. So we use exercise in front of the mirror. We use resistance bands. We use weights. We want to enhance that sensory feedback. The other thing that training big does for the brain is it helps reduce some of your stiffness. So I always talk about my patient like surfing. If you look at this picture of this surfer, if they get up on the board and try to hold themselves really rigid, they're going to get knocked over the second they get hit by a wave. To surf successfully, you have to be kind of loose on the board. And so, because Parkinson's is driving rigidity and stiffness, we need to work through some of that stiffness so that you have more flexible balance reactions. On the bottom is my patient Harvey, and Harvey lives on a farm, and he was having difficulty moving around on uneven surfaces on his farm. And so we were working on trying to get him to take bigger steps. And and when I would cue him to take a big step, he felt very off balance with it. So if you look at this exercise at the bottom, we're implementing a lot of these tools in this one exercise. So the first thing that we did is I put this heavy band across Harvey's waist. So instead of just telling Harvey to take a big step, he has this sensory input in the band. So he can take a big step and pull into the band, and that helps him feel how to generate a bigger step. We've also put a hurdle on the ground. So back to our hiking example, sometimes what happens is you don't realize that you aren't picking up your foot enough until you feel it hitting the hurdle. So I could see that Harvey wasn't picking his foot up a little bit, that he was not picking his foot up enough, but he couldn't feel that until we worked on taking big steps over the hurdle. The final thing we're doing in this exercise is we're just working on his posture. So he's having to take a big step over the hurdle, pull into the band, and then he's doing that big postural correction to keep him more in the middle. And so after we trained with this exercise, he actually started to feel a lot more comfortable when all these assists were removed. He was able to feel how to take a bigger step. So we're trying to get all of these different sensory systems to integrate a little bit better in the brain. And these are some of my key principles when I'm working with someone with Parkinson's disease. So principle number 1 is to embrace the wobble. So if you think about if you wanted to get stronger, it makes sense. Like, I can't get stronger lifting a pin. I've got to lift a heavy enough weight so that the last few repetitions are difficult. The same goes for balance. If you're doing a balance exercise and you feel 100% stable, it's not challenging enough. So I think about like that 70 to 80%. I want you at like a 70% success rate, because that wobble, that error signal is what gets the brain to say, okay, hold on, what's happening here? I'm wobbling. We gotta kick in our inner ear or our ankles and figure this exercise out. The other thing about embracing the wobble is that if someone comes in and they say, okay, I'm working on standing on one leg, but I'm holding on to the counter when I am doing it. The second your hand goes down, your brain isn't kicking in your inner ear or working on your ankle proprioception. It's learning to control your balance through your arm. So we have to find something that makes you wobble, but that it's not so hard that you have to hold on. Now, my caveat to this, if you're someone that uses a cane or a walker, it's very appropriate to practice balance exercises holding on, because you do control balance through your arms. But if you're really trying to not use a cane, then we probably have to find something that you can practice without holding on. Okay, so we're wobbling, we aren't using our hands, and then we want to break that visual crutch. So we know in Parkinson's, you are very likely overusing vision for stability. So we want to try to integrate exercises maybe where you're closing your eyes, or instead of facing a wall when you're exercising, do that exercise looking out the window. Because again, that if your brain can't focus on a specific visual point, it's going to learn to use your inner ear and your ankle sense of balance a bit more. So we want to make your ankles work. So we want, a lot of times we work on standing on uneven surfaces. So we have balance balls and foam. We really want to train that ankle sense of balance. That's really important to improving sensory integration. If we always have you on a firm surface, you're going to feel very off balance in the real world on uneven pavement and varied textures. And then finally, we want to, if we have all of that in place, to get these exercises to translate to improved balance in the real world, we need to add that multitasking component. Um, so we need to potentially add like another layer with some sort of cognitive task that you have to perform while you're balancing. And that part can feel really torturous sometimes in the clinic. So here's an example. This is a patient who, again, was complaining of decreased balance on uneven surfaces. So we know that we want to make his ankles work. We want to train him on an uneven surface. So when we start him on the exercise, he's standing on this uneven ball. And and initially, we're giving him a point. We're getting him used to that wobble, and we're giving him an X on the wall to look at. And a lot of times people will say, like, they feel better with a balance exercise when they can focus on something. Again, the problem is if we stop there with that exercise, where he's going to start to become more visually dependent. So once he got used to the ball, then in the second picture, we're making it harder. So he's standing in front of a mirror. He's having to reach and tap to these lights. So there's, again, this visual complexity. And then, we could say, okay, now you're going to, every time you hit the lights, you're going to name the months of the year backwards. We want to keep kind of introducing complexities so that he's working through that wobble. So training without your hands can be really intimidating at first. And so this is a setup of how I would start with somebody in their home. So what I do is I set people up in the corner of their room so they have walls on either side and put a chair in front. So in the first picture, she's standing on this half foam roll. So again, we're trying to make her ankles work and put her on um, this uneven surface, but we're giving her this chair in front so she can touch down and feel safe doing such a challenging exercise. In the second picture, we're working on eyes closed balance. So we're giving her the stable floor underneath her. She's in the corner, she has the chair in front, and now she's going to try to close her eyes and balance. Okay, so what I'm going to do, I'm going to stop the share and we're going to try to do a quick balance workout together. So I'm going to try in this workout to use all the components that I would do with somebody at home. So you can stay sitting, you can just watch, but if you want to get up and exercise with me, you're more than welcome. I'm actually going to turn off my screen 1 minute because I'm going to move my computer. Okay, so I'm back. Okay, so first step to a balance exercise is we actually want to get your heart rate up. A good boost to any balance exercise, aerobic exercise, getting your heart rate up sets your brain up to do better learning during the exercise. So we're just going to march. So our first step, we're just trying to get the heart rate up. So, spending 5 minutes on the bike, walking on the treadmill, doing something aerobic before you work on your balance. Okay, now we're going to do some punches. So we're going to punch side to side. Good. And now we're going to start to punch overhead. And then final exercise. It's hard to see, but I'm tapping my knees. Okay, so that was our abbreviated aerobic workout. Now I want to train big. If I'm going to work on a challenging exercise, I really want to feel where I am in space. So we're going to start with our hands forward. We're going to squat down, and then we're going to open big, really dramatic. So we're going to come down and up. Really big movements, get our posture up tall, and really feel where we are in space. Down and up. Okay, now I'm going to come down into a fist, and I'm going to reach up tall. Down and up tall. And really, you can't see my hand, but when I'm reaching up, I have a big open hand. Down and up. Down and up. Okay, so I've got my heart rate up. I've trained big. Now I want to work on my ankles. So I'm going to tip down a little bit. So I want you up on your toes and back on your heels. Toe to heel. You see me from the side. Up on my toes, back on my heels. You also potentially can walk around your room. I'm going to walk on my toes a little bit. I'm going to walk on my heels a little bit. I have one of these half foam rolls, so I know you guys don't necessarily have. This is a half foam roll. So a lot of my patients, when they start their balance exercise, we're really mobilizing. We're really trying to get their ankles nice and mobilized. Okay, so now we're going to work on an uneven surface. So pads, Bosu balls. You can flip this either way, these half foam rolls. So the next component of my patient's balance exercise is some sort of uneven surface training. Okay, the last component. We want to play around with eyes closed balance. Again, this is a really big group today, and this isn't going to be safe for everyone. So please just try it in sitting, or just watch me for right now. But what I'm going to have you do is I'm going to have you stand with your feet shoulder width apart, and then I want you to close your eyes. Sometimes what happens, you can open them again. So sometimes what happens when somebody closes their eyes, again, if I'm visually independent, I'm going to feel lost initially. So now what I want you to do, I want you to close your eyes and I want you to feel the ground underneath your feet. And I really want to pay attention. Your brain really wants to use vision, but I really want to focus on that connection of your feet to the ground. So you want to feel, is my weight more in my right foot or my left foot? Is my weight more in my toes or my heels? Okay, open. So when I have somebody work on eyes closed balance, I really want to start on a stable surface and make them pay attention to that connection of their feet on the ground. The last thing that we're going to practice today is that idea of eye-head coordination. What I want you to do is take one step forward, and I'm going to have you hold your thumbs up, okay? And then what you're going to do is you're going to follow this thumb. So you're going to drop it to the side, and you're going to turn your head and watch your thumb and come back up. And then you're going to drop to the other side and come back up. So again, if that exercise was really hard, you might need to adjust. You might need to make your feet a little farther apart to start, or adjust your base of support. But what we're going to do is we're going to pay attention. So lock your front foot into the ground. And as we add this rotation, I really want you to lock into your front foot. So we're going to drop our thumb to the side. I have all of this vestibular and visual input, and I'm really trying to pay attention to my foot on the ground. Okay? So that was a really quick rundown. Everyone can sit down. I'm gonna turn my camera off again, 1 second. Okay, so I'm gonna share my screen again. So it's hard in a group this size to recommend a program for everyone, but to me, this would be a pretty comprehensive 20-minute balance warm up or workout. So we warm up for 5 minutes. Again, we're focused on aerobic exercise to boost the brain for training. Then we're going to train big for 5 minutes. We want to reset posture, our sense of midline. We want to reduce rigidity, and we want to improve body awareness. Then we want to train our ankles. So we want to mobilize our ankles and think about some balance training on an unstable surface. And then finally, we want to do that visual piece. So we either want to add head turns or eyes closed balance training. So these are sort of the components um, to help you have a more robust balance workout. So I'm going to open up to questions. I know talks like this can be very overwhelming to put all of this into play yourself. So I really encourage you, if you've never worked with a physical therapist, we here at the Parkinson's Fitness Project, we have clinics in Seattle, in Leschi, and Bellevue. I'm also happy to help you find a physical therapist in your area. And then we also have our virtual program called Daily Dose. And Daily Dose is all about, it's 20, 25-minute workouts, putting all of these things into play that we talked about today. So I'm going to go ahead and stop the share and open things up to questions.
So there is one question in the chat. Do you have recommendations for postural instability?
So, I mean, everything we talked about. So we have to figure out what's causing your postural instability. So, like I said, we have to figure out first, like eyes, feet, inner ear. We have to see if that instability is being caused by faulty sensory input. And then we have to start to train these different sensory systems to work together a little bit better.
Right. Kathleen was saying that they have found that dancing big movements and reaching and stretching really gets the cardio up, and holding onto the chair with the rhythm of the music, and that the thumb thing that you said has really helped them a lot.
Okay,
So,
great.
yeah. And Jennifer asks about a physical therapist in Spokane. I can try and help with that, Jennifer, or Jenny, if you have any recommendations.
I'd
But
have
we
to
can work that.
consult my master list, but I'll
Yes,
send these slides out and it has my email, and I'm happy to help you find somebody.
yes, yes. I can help with that as well. So just let me know. We'll get the magic list from Jenny, and we also have some resources for that. So any other questions before I stop the record that might be good for folks? All right. Thank you, Jenny, for all of this. I'm going to stop the record.